Okie dokie, we are going to go into a tour of men's and women's healthcare concerns. Let's start with the men this time. We kind of have to pick men over women. Women always get to go first, so we're going to take the men first. And we're going to talk about some of the men's reproductive concerns, basically male anatomy concerns that we have. The first two are going to be involving the prostate. One is the benign prostatic hypertrophy, the benign form of prostate enlargement. Then we have prostate cancer, the non-benign form of prostate enlargement, and the procedure, prostate surgery for that. Then we talk a little bit about testicular cancer and ED, erectile dysfunction, not emergency room. BPH, benign prostatic hypertrophy, its name is right there. It is benign, not cancerous. So anyone with BPH does not have prostate cancer. They just have a really big prostate. The cues for BPH is basically urinary, and I'm toying with the idea of moving BPH into the urinary lecture. I may move it to the urinary lecture, we'll see. But the reason it's a urinary lecture is because it causes urinary retention, and we can see that the prostate is this nice spongy organ here that enlarges and eventually will cause obstruction of the urethra there. The bladder will keep pushing fluid out of it as it fills, even if the urethra is somewhat narrowed, which is what happens as that prostate enlarges. So what happens is you get frequency and urgency because the bladder is trying to expel urine. So the bladder is doing just what it's supposed to be doing. It's contracting, but it's meeting resistance. So you get the frequency and the urgency because you need to go to the bathroom. The bladder is telling you need to go to the bathroom. Lots of getting up to pee because with the bladder can push with all its might and it only pushes a little bit out past that swollen out prostate. So you get small, tiny, infrequent difficulty initiating the stream. The bladder has to push down real hard to push past that prostate. You get incontinence of urine because that bladder is constantly pushing down, and sometimes the urethra will spasm and let some urine out when it doesn't mean to. So you do have some incontinence, some dribbling of urine, frequency, urgency, and that's just because there's a blockage on the urethra there. It is diagnosed with every man's favorite exam, the digital rectal exam, because the rectum is right over here, and so you can put a beautiful finger on there and actually touch the prostate. They can put the fingers right on the prostate and kind of palpate the prostate. They palpate the prostate for nodules. It'll protrude as it enlarges into the rectum there. So with the digital rectal exam, you can actually feel the protrusion of it, and that a benign prostate that is just swollen will not have firm nodules on it. They can also test a blood test, the prostate-specific antigen. Elevated levels just mean that you have some kind of big prostate. It's not necessarily a cancer screening test. PSAs will be elevated in benign prostatic hypertrophy, and they will be elevated in prostate cancer. So prostate-specific antigen is just a disease of the prostate that you can measure PSA levels, but it doesn't tell you whether you have cancer or not. You do have to do a biopsy of the prostate to diagnose, and that is done with a cystoscope, which goes in there and actually will biopsy a piece of the prostate. So it goes up through the urethra and biopsy the prostate. So worsening cues for this, again, you're going to have frequency, urgency, difficulty in getting stream going, incontinence, dribbling of urine. But the worst case scenario is urinary retention and hydronephrosis, or urine backing up into the kidney and causing causing kidney damage. You can also have frequent UTIs if the bladder is never emptying. Again, urine is a great place for for bacteria to grow. Bacteria can get their way up there, and then they've got a home that never fully empties out of fluid, and it's a great place for bacteria. So frequent UTIs, kidney damage, urinary retention are big problems with BPH. So we're going to keep an eye on their urine output, making sure it is sufficient. Pain, urgency, frequency, incontinence. Ask your patient, are you dribbling? Are you having a lot of frequency? They can do PSA and testosterone levels. Testosterone levels do cause, high testosterone levels do cause the prostate to swell. What are we going to do for prostate? BPH. They're going to prevent the growth of the prostate or decrease the size of the prostate. And the only thing that decreases the size of the prostate are testosterone inhibitors. I guess it doesn't say anti-androgen. Androgen is another word for testosterone. So they are anti-testosterones. They're called amides. I can't remember. I think the one's flutamide. But those are you want to reduce the testosterone level. So they have, and they will reduce the testosterone right there at the prostate, where the prostate is making it. These 5-alpha reductase inhibitors also, they block the prostate from absorbing testosterone and working on it. So anyway, those are the two meds for it. We're blocking testosterone. They will prevent the growth and decrease the size of the prostate. So those two will fix the problem. Alpha blockers, which we may have gotten caught on an exam earlier about a Flomax, alpha blockers will relax the smooth muscle of the bladder and the prostate so that the urethra is not as obstructed. It eases those symptoms of urgency and frequency because the bladder is able to empty properly. So alpha blockers are the relaxing of the smooth muscle of the urethra. It relaxes the bladder. It relaxes the prostate. It kind of relaxes everything up so that then the urine can leave the bladder. So alpha blockers are symptom treatment. They don't decrease the size of the prostate. They help the smooth muscle of the bladder, the urethra, and the prostate. If there is obstruction, if we get our worsening case scenario where there is obstruction, the treatment for an obstruction is to remove the obstruction. Well, we're not going to remove the prostate just by ourselves, but we can put a catheter in to bypass the obstruction. Is it easy to put in? No, it's not. We're trying to put a catheter into this area. So a curved tip catheter will help you get past that prostate. It may cause some bleeding as you are entering the catheter. If you're inserting a catheter here, let's see if it lets me draw. If you're inserting your Foley catheter, it will meet resistance here at the prostate. And so that curved tip helps tip it back towards the bladder where it needs to be. And putting a catheter past a prostate is a memorable event. You do hit resistance, and it is hard to pass. So I've seen urologists called because we can't pass the catheter into a BPH patient, and they are not pleasant passing a catheter. It is the roughest thing I've ever seen, and it does cause some bleeding if you're trying to get that catheter through the prostate, open up the urethra. You're basically pushing that catheter past the obstruction. I do not proceed if there's that much of a blockage, but we'll let a urologist come in and get that catheter in. And the urologist just go ahead and push it in there. It's bleeding. It's really kind of ugh. But a catheter is needed to bypass the obstruction. So a catheter is indicated, and if you can't pass it, then that might be a urology consult to have a urologist come in and pass that Foley into there. But we do need to get a catheter in because, as we learned in the GU section, if we do not bypass the obstruction, you can end up with post-renal damage, post-renal acute renal failure. The surgical treatment is to resect. Again, if the testosterone blockers do not work to reduce the size of the prostate and you do have obstruction, then surgical treatment is indicated, where you can resect a piece of the prostate, they can laser away part of the prostate, and they can ablate or burn away part of the prostate. So we'll talk about those when we talk about the prostate procedure. If you are having benign prostatic hypertrophy, you're supposed to avoid antidepressants, decongestants, antihistamines, things that kind of stimulate the sympathetic system, because we want something that's going to relax and let the smooth muscles open. If we are doing ephedrine, like what's in decongestants or antihistamines, those actually stimulate the sympathetic system. Anticholinergics, cholinergic, colon is rest, digest. Cholinergics mean parasympathetic system. If we block the parasympathetic system, we are causing smooth muscle constriction, and that makes obstruction worse because the urethra is already having trouble, and you take something like ephedrine, which is going to cause your urethra and your bladder to kind of spasm or tighten up. That can cause worsening obstruction. So in a BPH patient, just caution them. There's plenty of decongestants that do not have ephedrine in it, that have pseudoephedrine, fake ephedrine. But those decongestants, even pseudoephedrine, does have some ephedrine-like or ramped up. Anything that will amp you up is basically stimulating your sympathetic system. So we want to avoid those things in BPH. Avoid fluids just a few hours, and not avoiding fluids, not restricting fluids, but just avoiding fluids for maybe the 3 to 4 hours before bed to reduce the episodes of getting up or frequency at night. Because again, if you're filling your bladder, it's going to be frequent and urgent to try and get that thing emptied. So just changing your fluid intake, that you get full fluid intake, adequate fluid intake, but just during the day rather than over at night. Alcohol and caffeine contribute to frequency, and definitely be on the lookout for signs of a UTI, and especially you're at higher risk of pyelonephritis because of obstruction. So those are our teaching points. Prostate cancer has the exact same symptoms, really, as BPH. The difference is found on the digital rectal exam, our fun exam again. When they go up there now, they can feel, instead of just the swollen prostate, you can feel these firm tumorous nodules. You can feel the tumors on the prostate, or if you were trained to do so, could feel the firm nodules on the prostate. The prostate physician specific antigen would be elevated, but again, that just means prostate disease, not that you have cancer. And again, they would do a biopsy of the prostate via cystoscopy, just like they would with BPH. There is no way to tell the difference between the cues on whether it's prostate cancer or BPH. It has to either be done on the digital rectal exam, whether there are nodules or no nodules, or on the biopsy via cystoscopy. Again, the same problems are the urinary retention, hydronephrosis, frequent urinary tract infections, and this, if it is not treated, again, can metastasize to the lymph nodes. The lymph nodes are right next to the prostate, very easy in that stage 4. You can see in the stage 4 picture there, the tumor getting into the lymph nodes there. This is where they would do a radical prostatectomy. They would actually remove, it's very similar to the prostate surgery for BPH. They're just kind of shaving off a little bit of the prostate, just enough to open the urethra. Here they're going to remove the entire prostate gland and probably part of the bladder. If they do this radical prostatectomy, you can see it's going to have some bladder it's going to have a lot more bleeding and debris after this surgery than it would be after a regular prostate surgery. There's cryoablation, where they can freeze the tissue. You can do radiation. They can either do external or brachytherapy, where they put radioactive seeds into the cancerous area and let that kill off the area. It's localized radiation, much lower dose than external radiation, spares the surrounding tissues. But this is where the patient, if you think about our kind of chemotherapy add-on from the hematology lecture. Patients with brachytherapy or little radioactive nodules, wherever it's placed, they do brachytherapy for almost any kind of cancer. It just means that radioactive little nodules are put in. They do brachytherapy for thyroid. They can do brachytherapy for breast cancer, for any cancer really that has a tissue to insert a little seed into. It is an option, but the patient is considered radioactive for that time that they are carrying these little radioactive seeds in their tissues. And so a radioactive patient should be keeping like a 3-foot distance, kind of like a 6-foot COVID distance, keeping their distance about them if they have brachytherapy. So that would go for any cancer that has these radioactive seeds implanted. It's called brachytherapy when you have radioactive nuggets placed in the tissue to locally radiate tissue. And then testosterone deprivation, again, the androgen inhibitors, androgen receptor blockers, and if it has gotten, the cancer has gotten down into the testicles, or sorry, not the cancer gotten down to the testicles. They can remove the testicles to reduce the testosterone level because that is going to cause the prostate to grow. And if you are having tumors, the tumors will be stimulated to grow. Prostate cancer is the most common cancer among men except for skin cancer. Skin cancer is the most common, but it is the most common male-only cancer. Second leading cause of cancer death in men, the first being skin cancer. Annual digital rectal exams is the screening. You can do prostate-specific antigen screenings. Again, that won't tell you that you have cancer. It just tells you you have something pathologic with your prostate. The digital rectal exam can tell if there are nodules, so that's why you get one after 50. High processed meat intakes, high fat products, low vegetables. The more high fat you eat, the more hormone you end up having. Hormones are fatty. They're made out of fatty molecules. So high fat diets do lead to excess in hormones. So that is prostate cancer. Let's look at the prostate surgery. The two most common are the TURP and the tuna. The transurethral, which means that the surgical instruments go through the urethra. Transurethral resection of the prostate, that's kind of a roto-rooter where they put the thing in there and kind of roto-root it out. And then they have the needle ablation where they burn away part of the prostate. So you can imagine that you expect afterwards, you just put surgical instruments up there and removed a piece of tissue around the urethra. It's going to be bloody. So we expect pink-tinged, cloudy urine, not because there's an infection. It's hard to tell if there's an infection just looking at the urine. It is pink-tinged. They went in there and made it bleed. It's cloudy because of the surgical debris and the sediment that is draining out of the urine. And there is a Foley catheter in place because, hey, if you did that to my urethra, it would swell. And so they're going to put the Foley catheter in post-procedure, probably keep it for a couple of days post-procedure until the urine clears up. Aggressive hydration to flush debris and keep it moving from the bladder. Bladder spasms, urethral spasms are common afterwards. Again, we just shoved a tool in there. The urethra is going to spasm. The bladder might spasm, causing pain, urgency, frequency. The Foley catheter is in place for that. There is postoperative pain, and that will be managed by ordered medications, and they may come back with continuous bladder irrigation, or they may need it implemented or started depending on the amount of debris. You don't want that Foley that's already placed because they know it's going to swell and they know it's going to bleed and they know it's going to drain debris. If that gets clogged up, we have no way of really keeping urine flowing. So continuous bladder irrigation will either be done proactively to avoid it, or will done, if you do have obstructions of the catheter. Continuous bladder irrigation is just going to continuously put sterile saline into the bladder to allow the bladder to flush. And remember, all this debris from the prostate, if I can enlarge this picture here, let's see if I can enlarge this picture. I want to make you bigger. There we go. If we take this picture here and look at where there's going to be blood and debris from this area, it's going to go back into the path of least resistance, and it's going to drain into the bladder. So it's going to drain into the bladder, but then the Foley that is then placed in the bladder to drain out can still become obstructive with this debris. So the debris is going to drain into the bladder, and then we need to let the bladder drain into the Foley. So that's where the continuous bladder irrigation will put saline just into the bladder to keep this debris rinsed out, basically. So continuous bladder irrigation, if you need a refresher on continuous bladder irrigation, then I do have the CBI PowerPoint. I think we did that as a demo. I do believe I have the demo on recording. I think I did the demo. I'll double check and make sure I did. Continuous bladder irrigation. What we do not expect is we don't expect hemorrhage. We don't expect bright red blood from the Foley drainage. We don't mind pink tinged. We don't mind small blood clots, but we don't want bright red hemorrhaging drainage. That could be a sign of bladder perforation, urethral injury, hemorrhage, and we'd want to make sure that got treated right away. Infection, prostatitis, again, this is if you're putting surgical instruments into the urethra, you can get an infection of the prostate gland. You can get an infection in the testicular area. You could get infection in the bladder. Keep an eye out for any signs of infection. Urine retention, keep the Foley flushed and draining. And then after the Foley is removed in a couple of days, make sure they continue to pee appropriately. There can be erectile dysfunction after prostate surgery due to damage to the area around there, and there could be infertility. The ejaculation could go back into the bladder rather than the correct flow based on damage that is done in there. So that is prostate surgery in a nutshell. Let's talk a little bit about erectile dysfunction. I'm so glad I'm not doing this class in person. It's just always awkward. Erectile dysfunction is being unable to create or maintain an erection. The reason that you get erectile tissue is due to blood flow. You need blood flow to get stiff. So there's extra blood flow that is allowed out of the veins, and that is what causes the erection, is increased blood flow to the area. So anytime we have a reduction in blood flow or damage to small vessels, you can have erectile dysfunction. So anything that reduces your blood flow. So atherosclerosis, vascular disease, diabetes, hypertension, or any medications that cause vasoconstriction can cause erectile dysfunction. Neurological diseases or decreased innervation to the area can cause erectile dysfunction as well. So the treatment is, if we are having a reduction in blood flow, the treatment is to help blood flow and dilate blood vessels. So this is a great thing. There's some specific vasodilators that work on small vessels, and they are actually used in pulmonary hypertension as well, these direct vasodilators. They do smooth relaxation of the veins, and actually they will use these erectile dysfunction meds, like I said, in pulmonary hypertension, because if you have very, very tight pulmonary vessels, then you can't get blood flow to your lungs very well. So they use these dilators for pulmonary hypertension as well as erectile dysfunction. But it is a vasodilator, so it works great when they work, but don't use them with another vasodilator known as nitroglycerin. So nitroglycerin also dilates veins and blood vessels. And so when you take two vasodilators together, what is going to happen to your blood pressure? It's going to drop. So see this all the time. Patients having a good time. They're having a little chest pain because they're having a good time. They took their Viagra. They're having a great time. They're having a little chest pain. And they take their nitroglycerin with it. And now you've got double vasodilator, no blood pressure, and you pass out. So do not take any erectile dysfunction meds with nitroglycerin. And like anything that is supposed to have a peak and then it's supposed to wear off, if your vasodilators work too well, you can get stuck with a priapism, which is an erection lasting more than 4 hours. Very painful, and the blood flow is so good that it is continually maintaining the erection, and it can't, the blood flow doesn't go away, and so basically the erection lasts for a long time. So seek medical help if you do have a priapism. They might have to do something to or antidote your vasodilator dose. This is more is not better. More is going to cause decreased blood pressure. Testicular cancer is our last men's stop. This is the most common type in young men, and it is the most curable cancer, but it can be deadly if left going too long, but it is easily curable by removing one of the testes if you do have. So the treatment is to check them. Check them routinely for swellings or lumps, and report any swellings or lumps to a provider. So it's called the testicular self-exam. Tell your young kids to go ahead and do it. It is important. I actually have a friend of mine whose son died of testicular cancer. He got it when he was 19, but apparently did not want to tell anybody that there was something wrong down there. He thought it would just go away, and by the time he let somebody know, it had already metastasized. So it is possible. And most of these, I think they metastasize to the lymph nodes, and then they can get everywhere. The treatment is very easy for testicular cancer. They will do an orchiectomy, which is removal of the involved testes and spermatic cord, chemotherapy, radiation, but they preserved one for fertility. So anyway, testicular cancer, check them. It's a fun procedure. We're going to head into the women's land now. We let the men have their turn first. For women, we're going to talk about polycystic ovary disease and endometriosis, and then we're going to talk about the cancers of the female tract and breast cancer. Now, breast cancer is not uniquely female. Men can get breast cancer as well, but just not as high of an incidence. So I put it in the female concerns, but by no means is it solely a female issue with breast cancer. Men have them too. Polycystic ovary disease, very common. This is due to benign cysts on the ovaries due to a hormone imbalance. These fluid-filled cysts can rupture, cause a lot of pain, can cause infertility. The cues are very vague. Most women's symptoms, sorry women, are vague. Irregular menstrual periods, you could be amenorrheic, but the cues that are common with polycystic ovary disease is the weight gain, acne, unwanted hair growth. These are the big ones. It's kind of hard to tell. Irregular menstrual periods, heavy, light, amenorrhea, those are hard to tell. Some people don't even know they have polycystic ovary disease until they're trying to have a child and they get their hormones checked. But usually we'll go with weight gain, acne, unwanted hair growth. There's extra progestin and progesterone, I think it's progesterone. There's extra progesterone, and it's just basically a complete imbalance of all the different hormones. So those are common cues, but again, vague. Doesn't really mean a lot unless you get your hormones tested. The thing that is dangerous about it are the worsening cues, your increased risk. And it's such a high increased risk that they actually prophylactically treat for cardiovascular disease and type 2 diabetes. Very, very high increased risk with polycystic ovary disease. So they will monitor blood pressure, cholesterol. If you are diagnosed with polycystic ovary disease, they will be monitoring your blood pressure, your cholesterol, and your blood glucose because of the increased risk of cardiovascular disease and type 2 diabetes. What do you do to treat it? Oral contraceptives balance the hormones. So again, oral contraceptives are not a political debate. They're actually a treatment for polycystic ovary disease. There are some symptom treatments. Spironolactone will treat, it's an androgen blocker. It's a testosterone blocker. So women who don't want male hair growth, if we block their levels of testosterone, that will treat the male pattern growth that they're having. Metformin can prevent and reduce your chance of diabetes. Statins will reduce cholesterol. Maintain healthy weight. Obesity, again, increases hormone levels, not always in the right balance. So maintaining a healthy weight, managing glucose levels, and making sure that you're doing all the things you need to do to reduce cholesterol. But the treatment is oral contraceptives. So that is polycystic ovary disease. Endometriosis is bleeding uterine tissue outside of the uterus. So normal endometrial tissue outside of the uterus, and it bleeds. It has a period. It's just can't get out of the uterus. You can't bleed out. So these little tiny microbleeds are happening due to this menstrual tissue that is sitting on your intestines or on your fallopian tubes or on your ovaries or on the outside of your uterus. There's lots of sites where this tissue, I don't even know how it gets out there. But anyway, the blood will collect in cysts because the tissue bleeds, and so the white blood cells will kind of put it in a cyst and clean it up eventually. But the rupture of these cysts causes a great deal of pain. The swelling of these tissues causes pain. So very painful periods, pain with intercourse, pain with bowel movements or urination if the endometrial tissue is near the intestines. Excessive bleeding during periods can cause infertility. Again, it's mostly painful. The severe problem is multiple cysts or scar tissue. These adhesions this scar tissue causes abdominal organs to kind of stick to the scar tissue, and you can end up having intestinal issues as well due to these scar tissues. There is a higher risk of ovarian cancer as well with endometriosis. So what do we do for endometriosis? Oral contraceptives. We're going to control the amount of bleeding and the amount of time that you're having a period so that it will shrink this endometrial tissue. And they'll try to control ovulation and control the periods through oral contraceptives. Pain management is with nonsteroidal anti-inflammatories, heat, yoga, acupuncture, all that stuff that doesn't work when you're having a ridiculous amount of pain, but you try anyway. You can have abdominal surgery if it is causing lysis of it, if they're causing adhesion, scar tissue that's causing intestinal problems. They can remove the endometrial tissue, but again, if you can control the size and the pain with oral contraceptives, we're going to do that least invasive rather than more invasive of going in and actually removing the tissue. The goal would be to shrink it rather than remove it. The risk factors are higher levels of estrogen. So again, higher levels of estrogen are going to cause you to ovulate more, a family history of it, and so oral contraceptives again is going to be our treatment of choice for polycystic ovary and endometriosis. For the cancers, I don't need you to remember much about the cancers that you can get cancers for women in cervix, endometrium, which is in the uterus, and in the ovaries. Again, vague symptoms, increased bleeding, pain during sex. Well, we just said that's STIs, that could be endometriosis, it could be cancer, very vague cues. So do not remember the cues. There aren't that many that are specific. What I do want you to remember is that cervical cancer is drastically reduced by vaccines against for HPV. So an HPV vaccine will drastically reduce your risk of cervical cancer, and that cervical cancer does have a screening test called a pap smear. Should be done annually. A pap smear, they will recognize abnormal or precancerous tissue before it even turns into cervical cancer. So preventative treatment, pap smears, and vaccines to prevent cervical cancer. Endometrial cancer, again, that has vague symptoms, pain during sex, heavy bleeding. They'll just call it endometriosis. If the symptoms continually persist and they rule out other things, then they can go in and do an endometrial biopsy. So basically, when they're suspicious of any kind of cancer, or you're having vague or odd bleeding patterns or pain during sex, they're going to go in there, they're going to culture the area, make sure it's not an STI, make sure it's not bacterial or viral. They may call it endometriosis and put you on oral contraceptives, but the oral contraceptives don't help. If they are suspicious of a cancer, they will do a transvaginal ultrasound or biopsy if needed. There is a test called the CA-125 blood test, but it is not an approved screening tool. It is only 80% accurate on whether you have a risk of cancer or not, and it really only reflects ovarian cancer. So again, ladies out there, vague symptoms, but be persistent if you do feel that something is not quite right. The transvaginal ultrasound will see abnormal tissues, and they can do biopsies off of that. So again, do the pap smears, do your HPV vaccine, prevent cervical cancer, and for endometrial cancer or ovarian cancer, if there is anything that is off or the bleeding changes, get hormones tested, get transvaginal ultrasound just to rule out any of the reproductive cancers. For any reproductive cancer, the surgery is going to be hysterectomy, radiation, and chemotherapy. Again, we can do brachytherapy, which is the internal implants. So I kind of use a bunch of different words here. The internal implants is actually brachytherapy. Oh, can't spell it. Brachytherapy, and hysterectomy, which we have as our procedure here. This is a total exoneration, is quite a radical, and that's what that word is supposed to be. It's not extensurations, it's exonerations. And that just means where they basically gut out all of the female parts and they actually remove. That's rare because you would have to have metastasis to local organs. But that's where you can see they've removed the bladder, they've removed part of the large bowel, they remove all the female parts. The more common is the hysterectomy, which there are 3 kinds. So we kind of have that on our next slide. The hysterectomy. We have a total hysterectomy, which removes the whole uterus and cervix. We have a subtotal, which removes, so you can have any variety depending on what is going on. They try to preserve the ovaries if they can, because that is involved in your hormone balance and your menopause. So they try not to remove ovaries if you need a hysterectomy, unless there's involvement of all the tissues around it. So they try not to do the oophorectomies, which is removal of the ovaries, but the different hysterectomies all have the same post-procedure care. They will do a Foley catheter. Not all hysterectomies are done abdominal incision. Some of them are done laparoscopically. Some of them are done transvaginally, where they kind of go up through the vagina, remove the piece of the uterus, and pull it out that way. So they can be done laparoscopically, they can be done transvaginally, they can be done open abdominally, depends on what's going on. So the Foley catheter, again, is going to be dependent. A transvaginal surgery is going to have a lot more swelling, is going to be have a Foley catheter. But any surgery in that area that involves manipulation of the bladder can cause bladder dysfunction. So you're probably expecting to see a Foley catheter at least for the first few hours after surgery anyway. Aggressive hydration, postoperative pain. It is normal to have a little bit of bloody discharge for a few days to weeks. Again, this is going to be a loss of fertility, so depending on the age and the number of children that a woman has, this is a loss of fertility. We don't expect hemorrhage, so again, after surgery here, they will possibly use a peri-pad for spotting, but we don't expect peri-pads to be used frequently or have heavy bleeding from that. So let your patient know that if you're changing your pads more than a couple of times a day, a couple times an hour, to let somebody know. Infection, again, bladder dysfunction is possible due to manipulation of the bladder and removing parts, cutting things around the bladder. So monitor the urine output after the Foley is removed to make sure that the bladder is not dysfunctional. And VTE is a risk after. I should put that for every surgery. VTE is a risk after any surgery. And breast cancer. Again, women and men, but more common in women because you've got those little milk ducts. Breast cancer are nodules. There are different kinds of breast cancer, and I'm not going to make you memorize breast cancers, but just know that if you hear ductal carcinoma in situ, or in situ, I don't know if I'm saying that right, that is breast cancer that has not invaded surrounding tissue, is considered local and pretty easily treated. And then we have the invasive kinds. If you see all the different parts here that we got going on, these are the milk ducts here, are these guys. So when you have ductal carcinoma, you have a cancer of the milk ducts. The other kinds are, you can have cancer of the lobes or the milk producing areas. That gets infiltrated much easier. You can have inflammatory breast cancer. So you can have cancer of different parts. And then you can have Paget disease, which is actually a cancer of just the nipple only, not the milk ducts, but just the nipple tissue itself. And that is called Paget's disease. That looks a little differently. Most breast cancers are nodules in the duct area or the lobe areas, and Paget's disease is like a scaly, it has a lot of drainage, it's itchy, it's red, and it's just at the nipple area. So that's just a different form of breast cancer, but it's just localized to the nipple, Paget's disease. But ductal carcinoma in situ just means that it has not gotten into the breast tissue, more contained, and the invasive ones are, they're in the breast tissue itself, and so that could have a higher risk of metastases. And you can see that metastatic happens when the cancer cells break through the walls and get into the blood and lymph nodes. So this treatment is surgery. The one that you want to, or the one that is most preferred, is the breast conservation surgery. That's where they'll do a lumpectomy or a partial mastectomy. They remove some of the tissue. And the big thing with breast cancer are the two different kinds of biopsies. So there's either the conservation one, which is local excision of the tumor, and it comes with a sentinel lymph node biopsy. And a sentinel lymph node biopsy is described here. This is just taking one lymph node nearest to the tumor and going and sending it off during the surgery for a biopsy in the lab. So they'll actually look to see if that first node or the sentinel node, sentinel means first, so this is the first node that they take. They're just going to take a little piece of it, and if that little piece of the sentinel node has malignant cells in it, then they're going to take all of the lymph nodes around the area. If that sentinel node does not have malignant cells, then that's the only node that has been removed. and they finish the case. So sentinel node biopsy is less invasive and less complications. I'm trying to get over here so I can write. So the complications after breast cancer surgery aren't so much based on how much breast tissue is removed, it's how many lymph nodes are removed. So we want the sentinel node biopsy. That would be our best case scenario, is just removing that first node and hopefully finding no malignant cells in it, and then you can leave all of the axillary nodes alone. So sentinel node biopsy is what everyone wants to go for. You can still have a total mastectomy, which is a removal of the entire breast, with a sentinel node biopsy. Again, some women opt to remove all the breast tissue and then just check that sentinel node, that first node, to make sure there's no malignancy in the lymph nodes. If there is a malignancy in the sentinel node, then they do a total lymph node dissection, which is called an axillary lymph node dissection. And this one is the more invasive and more complications. So it doesn't matter. You can have a total breast removal and have it be less invasive if they've only done the sentinel lymph node biopsy. You can have the whole breast removed, and if you have an axillary lymph node dissection, you're going to have more complications. Again, all of them are usually followed up with some form of radiation, chemotherapy, can be internal, can be external. And breast cancer also has a hormonal therapy, and it is a estrogen blocker. So again, like we block testosterone in prostate cancer, we're going to block estrogen in breast cancer. So if the breast cancer is sensitive to estrogen, they will do a test on it to see if it's an estrogen receptive cancer. If it is, we want to block estrogens. So they have estrogen blockers, or estrogen, the aromatase inhibitors will block from estrogens from binding to the recynder site. They basically work the same way. They prevent the cancer from feeding off of estrogen, just like we prevent testosterone for prostate cancer. So for breast cancer, again, for the I'm going to have the surgery on the next slide. Stealth breast exam once a month is recommended for checking for breast cancer. Do it several days after the period ends. It's when the breast is most likely to be swollen, and you could feel the nodes. So do it several days after period ends. Mammogram recommendations right now for women 30 to 40, it's every 5 years. And then from 40 to 55, it's every year. And then if you're 55 and older, you can go to every 2 years, because breast cancer becomes less, the highest risk for breast cancer is between 30 and 55. I do have the hand and arm care after axillary lymph nodes dissection here. I also have it in the slide there, because that is one of our big complications. Well, it's expected, but it is kind of a problem after axillary lymph node resection. So you can see that if you don't have the axillary lymph node resections, they don't usually have drains, and they don't usually have lymphedema. The lymphedema and the drains usually come after a total axillary lymph node dissection, because you can see if they're taking out the lymph nodes, they are taking out, or basically pulling out, all of this tissue here. So if they're pulling out all of those lymph nodes, that's going to cause a great deal of decreased drainage in that area. It's one of our main lymphatic channels there for that side. So if you have the axillary lymph node dissection, which is the more invasive dissection, you are at higher risk of lymphedema, which is swelling of the shoulder and the arm on the side of surgery. And that swelling is just due to decreased drainage of any arm. So the lymph node is kind of like our our garbage system. It kind of cleans everything up. It's where the white blood cells do a lot of their work. They pull things into the lymph nodes, clean them up, break them down. And so that's all done in the lymph system. And so if you have removed the nodes in the axillary area, then the shoulder and the arm doesn't really have any lymph drainage and becomes pretty swollen very easily. So what we're going to do, if you had an axillary lymph node dissection, which is more invasive, we'll ask afterwards to avoid blood pressures, injections, and blood draws in that affected extremity. Avoid any damage to that arm or shoulder. So we don't want, don't lift weights in that shoulder. Any infections of that arm or shoulder, it's not going to drain well. So any infection, if you have a white blood cell response to that area, it will go in, do its job, but it just won't drain well. So we want to avoid infections of the arm or shoulder that's affected, avoid lifting heavy objects, avoid doing anything that's going to cause an immune response to that arm afterwards. So on our lovely lady here that's had a left mastectomy, if she's had an axillary lymph node dissection, she is at risk of that left arm and shoulder getting lymphedema post-surgery. For the rest of your life, the lymph nodes don't grow back, so the rest of your life you're at higher risk for lymphedema. So you'd want to be able to get drained. You want to reduce any white blood cell, any immune reaction to that arm. So avoiding insect bites, avoiding scratches, scrapes, any immune response to the arm or the shoulder is going to cause swelling of the arm or the shoulder. So drainage or keeping the arm elevated will help lymphedema, but also trying to avoid any damage to that arm is good. Post-operatively, so all these things are worse. Surgical drains, post-operative pain, lymphedema is all worse after an axillary node resection. So hopefully catching breast cancers early. It doesn't matter whether you have a total mastectomy or a lumpectomy. The difference is in the nodes. So if you can keep the lymph nodes and detect early, keep the lymph nodes from being involved, the breast cancer surgery will be much better tolerated. Seromas are just fluid, serous fluid collected under the incision. Most of them resolve on their own, but if you have a large seroma, a large collection of fluid, anything can get infected. You get an increased risk of infection. And the things we're looking for post-procedure is hematomas or bleeding, and they can compression wrap the incision area, warm, sour, warm compresses to help those hematomas get healed up better, faster, and always be watching for infection. And that is men's and women's in a nutshell. I will see you on the next lecture.